next presentation will be Monkeypox Vaccine Safety Review. In this panel, speakers will provide a review of data on the safety of the vaccines used in the United States to protect against monkeypox. We'll hear from Dr. Jonathan Duffy from the CDC, as well as Dr. Lamont Collins from DOD. Dr. Duffy, have your slides up.
Thank you.
I see your face. You have the floor.
All right, thanks. So I'm Jonathan Duffy. I'm presenting today on behalf of CDC's multinational monkeypox response vaccine safety team. So next slide, please. So I know you heard yesterday about the vaccine implementation and strategies, and so I just give a brief reminder that the preferred vaccine that's being used in response to the current outbreak is the Jynneos vaccine brand name. It's the live non-replicating vaccine that had initial U.S. approval by the FDA in 2019. And so it is licensed for the prevention of monkeypox disease in adults 18 years of age and older, determined to be at high risk for monkeypox infection, with the licensed dose being 2 doses of 0.5 mLs given 4 weeks apart. And so, this vaccine was evaluated by the FDA in clinical trials that involved more than 7,000 people who received the vaccine. So that's our sort of baseline clinical trial safety database. Next slide, please. So, of course, the other important context for the current outbreak is on the vaccine supply. The FDA did issue the emergency use authorization for Jynneos that allowed use in individuals less than 18 years of age using the subcutaneous dosing, and then use in individuals 18 years of age and older using intradermal injection of 0.1 mLs. Next slide, please. So I think you saw a little bit of this the other day. So CDC is collecting data. It's being contributed by the different jurisdictions on the doses administered. So this gives us some context for our vaccine safety monitoring activities on how many people have been vaccinated, how many doses they've received. So, this data is from last week and indicates that the majority of people vaccinated to date have only received the first dose, and people will be eligible for their second dose in the coming weeks and months. Next slide. And so this graph also shows that same administration data for the first dose by age. So again, this shows that the majority of use, the vast majority, has been in adults, with the younger adults as the most commonly vaccinated age group to date. Next slide, please. And so this is just the last slide on the administration data showing doses administered by sex, which shows that approximately over 90% of vaccine recipients to date have been male. So again, this just provides context and background. Next slide, please. So, as you're familiar with our safety monitoring systems that CDC uses for vaccine safety, these will be the same systems that are currently being used and will be used throughout the course of this outbreak. So this includes the Vaccine Adverse Event Reporting System, the Vaccine Safety Data Link, and then also VSafe, which you're familiar with from COVID vaccine safety monitoring. So I just go through and talk about what we're seeing in each of these systems a little bit. So next slide, please. So just a reminder, VAERS is our early warning system for vaccine safety managed by CDC and FDA together. This picture is just a slide we'd like to show. Shows our website, which is the preferred reporting method for the public and healthcare providers. Next slide. So important context for this particular emergency response and the emergency use authorization. Whereas, VAERS is a passive reporting system and relies on spontaneous reporting. The emergency use authorization does call that for vaccine providers are responsible for mandatory reporting of the adverse events listed here if they were to occur following Jynneos vaccine. And so this includes vaccine administration errors, whether or not associated with an adverse event, then serious adverse events, and then cardiac events, including myocarditis and pericarditis, and thromboembolic events and neurovascular events. That, again, just provides some context for the types of things that FDA identified as being important to monitor for in this context of emergency use authorization. Next slide. And so just a reminder that, the definition of serious adverse event is the standard one that we use under normal regulatory circumstances. Next slide. So now to just talk a little bit about what we've seen so far to date. So U.S. reports to VAERS after Jynneos vaccine. This is showing data through September 16th of this year. VAERS had received 856 reports, and this graph shows the number of reports received by week. And so as a reminder, the first case of monkeypox disease was identified in the United States on May 17th. And so the vaccination program has expanded over that time, and as the number of vaccines administered has gone up, so has the number of reports to VAERS. Next slide, please. So this table just provides some characteristics of these reports after Jynneos vaccine. So 84% have been related to males, which again is consistent with what we've seen from the vaccine administration data. And the dose in series, 72% have been for first dose, which again is consistent with where we are in the course of the vaccination program of the 2-dose series. And the route of administration, as I discussed, is of interest, is that had also changed in August from originally being subcutaneous as the preferred route to intradermal being the predominantly preferred route for adults. And so as of this point in time, 45% of reports to VAERS have concerned intradermal administration. And then there at the bottom, again, talking about the series classification, 99% of reports have been non-serious, with only 7 serious reports as of this date. Next slide, please. So when looking at the types of adverse events or just events reported, because again, administration errors, vaccine administration errors or deviations are called for mandatory reporting, and they actually represent approximately 40% of all reports are related to vaccination errors and not actually to an adverse health event. But when looking at the types of events reported, incorrect route of administration is the most common type of event, which is considered an administration error. And early in the use of the vaccine, there had been reports of people giving the vaccine intramuscularly instead of subcutaneously, and then following the emergency use authorization, a lot of these reports were then reporting people who were attempting to give the vaccine intradermally, but were having difficulties with that route of administration. So as far as the actual adverse events that are being reported, it's injection site erythema, swelling, injection site pain, and itching, which are, consistent with what have been seen in clinical trials. And then other common events that, are commonly reported for other types of vaccines. Next slide, please. So just transitioning to talk about the monitoring that will be happening in the Vaccine Safety Data Link. This is just a reminder that VSD has approximately a population of about 12 million persons per year under surveillance. So that's about 4% of U.S. residents. And as you can see on the map, we for our surveillance, we get data from 8 contributing healthcare plans and located in 6 different states. Next slide, please. So as of September 19th, the number of doses of Jynneos administered in VSD, there's been 18,000 approximately dose 1s and almost 4,000 dose 2s. So when you look at the nationally reported vaccine administration data, consistent with our VSD population, this is about 4% of the doses administered nationally that we have captured under surveillance in VSD. Next slide, please. So in VSD will be monitoring for these certain pre-specified adverse events of special interest listed here. So things like anaphylaxis and Guillain-Barré syndrome are of interest for vaccine safety in general, are not necessarily concerns specific to this vaccine. And then these other events, myocardial infarction, myocarditis pericarditis, stroke, and venous thromboembolism, again, these were selected based on the considerations that FDA had identified in the emergency use authorization. And of course, just from historical knowledge, myocarditis had been a concern with the older generation replicating smallpox vaccine. And so while that was not a concern that was identified in the clinical trials, it does remain a theoretical risk with the smallpox or monkeypox vaccinia strain vaccines. And so that's why just call attention to that as a reason why that is an adverse event of special interest. Next slide, please. And so this brings us to VSafe. And so the important thing to keep in mind about VSafe is well, as you know, it's a smartphone-based survey platform, but it was created specifically in the context of the COVID-19 vaccine safety monitoring. And so, of course, in the course of the preparation for the vaccine program, there was many months during which time the vaccines were under development in clinical trials, in which there was time to prepare the V-Safe system for the launch of the COVID-19 vaccines to the general population. And so this is a system that has not previously been used for any other vaccines other than the COVID-19 vaccines. And so it's been determined that, due to the success and the positive feedback received in the context of the COVID-19 vaccination program, that we want to use V-Safe to collect similar data in the context of the monkeypox vaccination program and outbreak response. But due to the fact that the system has not previously been used for other vaccines, this entailed additional administrative and technical work to create a new module. And so as of today, a monkeypox vaccine module of V-Safe is not yet ready for people to enroll in, but CDC has been working to make that available as soon as possible, and we do anticipate that V-Safe will be able to begin enrolling people, and people will be able to enroll and submit data in the near future. And again, this will be something that will be communicated and sort of advertised to vaccine recipients as a thing that they can participate in at the time that they're actually able to enroll. So that's something we're looking forward to. So next slide, please. So in conclusion and summary, just say that our vaccine safety monitoring to date in the context of the multinational monkeypox outbreak has not identified any new vaccine safety concerns, and that CDC is committed to continue vaccine safety monitoring throughout this monkeypox vaccination program. So with that, I'll conclude my presentation. Thank you.
Thank you, Dr. Duffy. Our next presentation is Dr. Lamont Collins. He'll be talking from the podium.
Good morning. Actually, Dr. Duffy and Dr. Carter yesterday have made my job a lot easier. But I do want to apologize up front for my Texas accent. So if you can't, we don't have an interpreter for that. So I do want to just put that disclaimer up. Okay, I'm going the wrong way. So I'm going to take a little different tack because the DOD has had a lot of experience, particularly dealing with ACAM 2000, which is the topic that I'm tasked to talk about. So I want to really focus this on our history of use of it and basically talk about lessons learned. And I think that'll be helpful, and particularly in regards to our utilization and help guide the safety concerns with it. So from a historical standpoint, we know that ACAM 2000 is a second generation vaccine, was grown out of single clones and isolated and grown out of cell culture. And remember, if we go back historically, this was a replacement of the old Dryvax vaccine. And so this was developed in 2007. And I think one of the things, particularly when we focus on the safety of this particular product, is that it's unique in its implementation. Remember that this utilizes bifurcated needles. And so one of the things that we learned from the DOD is that the individuals who are providing the vaccination have to be vaccinated with ACAM 2000. And so that's a very important issue, particularly if we're going to utilize this product as an alternative for the monkeypox, is that the individuals who are utilizing this, or if this is an option that whoever is vaccinating with ACAM 2000 has had to have been vaccinated with ACAM 2000. That was a criteria within the DOD as we educated our medical technicians and our medical personnel before utilizing this product is that they have had to have the vaccination. So the uniqueness of the bifurcated needle, but also the technique. The technique was very important, particularly in regards to individuals who had not had any experience with the smallpox vaccine versus those who had previously been vaccinated. And the number of vaccination tricks varied based on the past experience. Again, emphasizing the importance, if you're going to utilize this as an alternative product, that those individuals have that education background and know the importance of the process. The other thing that is unique with ACAM 2000 is the evolution of the progression of the vaccination site. And that was particularly important for several reasons. First of all, that it took a variety of dermatologic evolutions from starting off from a papule to a vesicle to a pustule, and to a pustule with crust. And that took a period of time. The importance of noting that is that it lended itself to spread. Remember, this was a replicating virus. And so one of the issues that we had and that we had to monitor, particularly from a safety standpoint, is making sure that we took care of the wound site, and especially with our active duty troops, to have them come back so we could monitor the progression and make sure that would give us some assurance that it was implemented the correct way and that it was following the normal pathway of the vaccination cycle. And so that's kind of described here in this diagram. And that's very important if we're going to use this as an alternative product, and that this has to be adhered to. Now, when we again focus on safety, why is it important to look at this evolution? Well, the unfortunate thing is that if the wound area is not taken care of, unfortunately with some of our active duty troops, that wasn't always adhered to. And so we had issues with auto inoculation, where they would spread it to other areas of their anatomy, or they would spread it to more vulnerable individuals who didn't initially have the requirement for the ACAM 2000. And so that was an issue that we had to monitor. We would see this frequently in some of our service members who participated in contact sports, if they were wrestling. And so, again, an important safety issue that we have to take in consideration if this is going to be an option. Okay, so in regards to the recognized safety issues, the development of ACAM 2000 was very similar. It had an adverse event profile that was similar to what we saw with the Dryvax vaccine. And so this was an issue both in the preclinical as well as the clinical trial. Because of the single cell progression, or at least the development of this vaccine as compared to the Dryvax. And if you look at the whole history of the Dryvax vaccine, where they scraped the bottom of the cattle, this was, quote unquote, a pure vaccine. And there was a thought that it was safer because of how it was developed. And so the initial thought was that we had a pure vaccine, although it did retain some of the adverse event profile that we would see, or that we saw with the Dryvax vaccine. And so that included a number of adverse events that were highlighted during the eradication phase. I'm probably the only one with all the gray hairs here, but if you remember that with smallpox vaccine, there was a global eradication program. And so these adverse events were characterized during that time period. And so because it was an eradication time period, at least the thought process was a little bit different in regards to how we viewed these adverse events, but they did occur. And this is a vaccine that has a high adverse event profile. And so that was characteristic of what we saw with the ACAM 2000. And so in regards to the adverse events that were characterized, primarily they focused on cutaneous reactions. Some of the cutaneous reactions were just subject of just the immune response, and so they were milder in regards to their occurrence. And so we saw things like erythema multiforme associated with that, sometimes more benign reactions, but generally they were characterized by not having the presence of the virus there. Unfortunately, what we do have to monitor when we utilize this product is we have to look at the immunologic profile of the individual who's going to be a candidate. So this was not a vaccine, and this is one of the things that we had to adhere to within the DOD. Remember that our program is a mandatory program. And so there was not a informed consent. But before anyone received the vaccine, we had to monitor them. And so these individuals, we had to make sure that they were immunologically intact, that they did not have immune compromised conditions. There is a proclivity, particularly because there is a higher incidence of cutaneous reactions. Individuals who had atopic dermatitis were not subject to receive this vaccine. And so monitoring and screening the individuals who receive this product is particularly important and crucial in regards to, again, the implementation of the vaccine. And so we did monitor all the at least generally recognized adverse events, progressive vaccinia, which was more characteristically seen in those individuals who were immunocompromised. We saw eczema vaccinatum, again, a adverse event that's associated with someone who has atopic dermatitis. And so these were, it's very important, again, if you utilize this particular product, those things that you take in consideration. So this is just an example of some of those cutaneous reactions that we happen to see within the DOD. First here is some of our more benign reactions, the erythema multiforme, which was a condition that occurred within several days of the receipt of the vaccine, but generally responded with just kind of symptomatic treatment, versus the case you see there in figure 2, which is a case of eczema vaccinatum of a child who happened to have atopic dermatitis, but was exposed because his father was inadvertently vaccinated. He came in close contact with his father, and here we ended up with it. So again, important that these type of things are taken in consideration if we decide to utilize this as a product for the treatment of monkeypox. So one of the things that you saw Dr. Duffy talk about is the mention of myocarditis. And honestly, this was not an initial thought with the implementation of this program. As a matter of fact, it had only been slightly mentioned prior to, even during the eradication time period. The Finnish army actually had described, and this was prior than 2002, they had described some incidents of cases here. Fortunately, as we decided that we were going to at least take in consideration cardiac manifestation. And so part of our screening was to take in consideration cardiac manifestation. So this was an underestimated risk, fortunately for us, that we did take it in consideration. So needless to say, myocarditis did rear its head, and especially in regards to not just ACAM 2000, but even with the Dryvax vaccine. And so we've had a lot within the DoD, a lot of experience recognizing and determining when myocarditis did occur. And so typically what you will see, and you saw this with our experience, even with the mRNA vaccines, that it has a particular profile, that these individuals are generally Caucasian males and between the age of 18 to 39. Kind of important profile to take in consideration, especially if you're looking at this as an alternative therapy. The advantage that we have within the DoD is that we do have a cohort of individuals who have had ACAM 2000. And so one of the unique things about, or at least what we've seen within the DoD, is that generally what we will see within at least with all of their adverse events, that it generally occurs with primary vaccinees. So the first time they receive it. Rarely, if ever. In fact, I can qualify it, that we have never seen an adverse event that has occurred with a revaccinee. And so this is something that we would see with our primary vaccinees. And so the natural history, unlike our mRNA myocarditis, it occurs a little bit later in its onset, so between 7 and 10 days, usually followed by the appropriate, well, not appropriate, but chest pain and dyspnea. And so that's generally the characteristic. Fortunately, similar to what we've seen with our mRNA associated myocarditis, is that it's a fairly benign course, and that these individuals responded pretty well with NSAIDs, short hospital durations in the majority of the cases. And we complied with the American Heart Association in regards to resolution of it. So we restricted their exercise profiles depending on if it was pericarditis versus myocarditis for that appropriate time frame. So when we look at what have we looked at within the DoD in regards to safety profiles? And so we've done two studies that I'll refer to. The first is by Fikes and Gordon, and this was a prospective study, basically that they looked at deploying troops and compared it with individuals who met the criteria for deployment but did not receive vaccination. And basically, there was just really a non-significant rise in their occurrence of myocarditis. The second major safety study that I happened to be a part of was a study led by Decker and et al. And basically, this was over a 10-year time period where we did electronic surveillance, looking at cases, particularly of adverse events of special interest, to see if there was a rise in any of them. And also there were chart reviews by medical specialists of the respective area, and really no significant rise in that. So this is a product that utilized effectively, particularly with the cautions that I mentioned, that can be very effective. Thank you.
Thank you, Dr. Collins. And I had no trouble with your accent from Arkansas. Any questions or comments from members of the committee for Dr. Duffy or Dr. Collins? Rob Schechter.
Thank you very much for both of those excellent presentations. Want to express appreciation both for the VSafe and the VSD systems over the years for COVID and how valuable they've been in COVID surveillance, and thinking about how important they could be for monkeypox and other newly emerging problems and vaccines, and just wondering to what degree that modules for new vaccines and VSafe can be accelerated, seeing how rapidly monkeypox vaccine has been given, and that administration rates may actually be declining at this point. And so realizing the importance of the systems, what measures could be done to accelerate or have a module in place for the next disease X or Y. Similarly for the safety data link, if there's a vaccine that's being given outside of VSD sites or it's more skewed towards public health administration, how can the power of VSD be applied to vaccines that may not be, where the patients may not be in VSD settings? Thanks.
Right. Thanks for the question. Even prior to this monkeypox outbreak, the expansion of VSafe to be used for other vaccines had been under consideration, and I think it was just unfortunate timing that there hadn't been a chance to put those that new sort of infrastructure in place to expand it beyond COVID vaccines. It was sort of bad timing that this outbreak started before that was able to be done, but I think that's certainly still under consideration of expanding VSafe for use for other vaccines in the future. And hopefully once that's in place, it will be a lot easier to have a more adaptable system for when these sort of emergency response situations arise. As to the vaccine safety data link, it's that is an existing infrastructure that, was able to begin monitoring the safety of the monkeypox vaccines as soon as doses were administered in that population. And of course, as you know, that the fact that the VSD is limited to certain geographic parts of the United States, and that is a known limitation that, that if the vaccines were not being used in those populations, it is not always fully informative. But I think as we've seen in this monkeypox outbreak, it's when we have a situation like this where the vaccine is sort of being used across the nation, and we do have the ability to capture information about those vaccines using the VSD.
Thank you for your response for the question. I want to thank both our panelists for this monkeypox vaccine safety review, and we will now move to our next panel, or our next presenter, I should say, evaluating evidence to address safety questions. Dr. Zanira Jelani from the CDC is going to summarize findings of 6 key topics that have been at the center of global discussions on vaccine safety during the early part of this 21st century. Dr. Jelani, I see your face on the camera and your slides are up. You have the floor.
Great. Thank you so much. Next slide, please. So the paper under discussion today is called Vaccine Safety Issues at the Turn of the 21st Century. And I'm giving this presentation on behalf of Dr. Laura Conklin, who is the former team lead for the Global Immunization Safety Team at CDC. The paper was developed in 2020 and published in early 2021, but I want to note that COVID is not a part of the discussion. And my final caveat is that the paper is very dense. So given the time that's allotted today, I'll really only be able to briefly discuss each topic, but I've left in hyperlinks in this presentation with the references so that the committee can review the references discussed at a later time. Next slide, please. So by way of some background, immunization is one of the largest contributors to progress in reducing infectious disease risk. global gains in vaccination coverage, however, are threatened by anti-vaccination sentiments. Misinformation is easily perpetuated through social media and public figures, and therefore sustaining gains in global vaccination programs requires maintaining public trust in vaccine safety. Next slide, please. The Global Advisory Committee on Vaccine Safety was established in 1999 by the World Health Organization to respond promptly, efficiently, and with rigor to vaccine safety issues with potential for global or regional importance. The group includes acknowledged experts in epidemiology, statistics, public health, drug regulation and safety, and a number of additional topics. They provide independent, authoritative scientific advice to WHO on vaccine safety issues, and they review general safety issues relevant to all vaccines and also vaccine-specific issues. Next slide, please. So the paper that I'm discussing summarizes 6 issues that have been reviewed by GACS between 1999 and 2019. And these issues are aluminum adjuvants, thimerosal, autism, autoimmunity, immune overload, and non-specific effects. These 6 key topics have been at the center of global discussions on vaccine safety during the early 21st century, and each issue has been linked to reduce public trust in vaccines and vaccination programs. Next slide, please. So this slide and the next show the reports that GACS has prepared based on these issues. We don't have time to discuss each report, but I want to highlight that the issues under discussion have been reviewed multiple times by GACS, and the committee typically returns to an issue when new information becomes available. Next slide. Next slide. So the first topic that we will discuss is aluminum adjuvants. Next slide. Aluminum is ubiquitous in the environment, and it's a component of many consumer products. It's used as an adjuvant to enhance immune response to vaccines in the form of aluminum oxide, hydroxide, and soluble salts. The mechanism of action is complex, including direct stimulation of multiple immune receptors, which enhances the natural immune response to antigen. The concentration varies greatly among different vaccine products, but it's less than the exposure from inhaling air particulates or antacid consumption. Aluminum is associated with encephalopathy at high intravenous exposures, and it's alleged to cause developmental delays, adverse neurological outcomes, and autoimmune syndromes. Next slide, please. Multiple clinical and epidemiological studies indicate that children who receive vaccines containing aluminum adjuvants don't have aluminum in their blood or hair above minimum risk levels established by ATSDR, that they're not at an increased risk of adverse neurodevelopmental outcomes. There's a notable study alleging an association between aluminum and autism spectrum disorders. This was an ecological comparison of aluminum content in vaccines and rate of autism spectrum disorders in several Western countries. GACS has reviewed the safety data on adjuvants a number of times between 1999 and 2012, and they have concluded that ecological studies should not be used to assess causal association because these studies can't link exposure outcomes to individuals. In 2012 as well, GACS reviewed an FDA pharmacokinetic model of aluminum-containing vaccines, and they concluded that the body burden of aluminum following injections of aluminum-containing vaccines never exceeds safe U.S. regulatory thresholds based on orally ingested aluminum. Next slide, please. So in summary, the evidence of safety on aluminum adjuvants is strongly reassuring, and the public concern is fueled by poorly designed studies and inaccurate extrapolation from such studies. Next slide, please. So the second topic under discussion is thimerosal. Next slide. Thimerosal is a mercury-based preservative, and mercury is a naturally occurring element found in the Earth's crust, air, soil, and water. It's used in vaccines for its antiseptic and antifungal properties, primarily in non-live vaccine multi-dose vials. Thimerosal is metabolized into ethyl mercury. All mercury compounds are neurotoxic at sufficiently large doses. And the concern is largely based on the methyl mercury experience, which is a different organic mercury compound with no neurotoxic effects. Fish consumption is the most common exposure, and fetal exposure, especially through fish consumption in pregnancy, has adverse effects on neurodevelopment. Ethyl mercury has different pharmacokinetic properties than methyl mercury. Its half-life is short compared with methyl mercury, and it's excreted rapidly via the GI tract. Next slide, please. There have been reassuring studies assessing neurodevelopmental outcomes in the UK and the USA between 2003 and 2007. There also have been large studies which have evaluated the association between thimerosal-containing vaccines and autism in Denmark, the UK, USA between 2003 and 2010, and they found no evidence that thimerosal-containing vaccines increases the autism risk. I want to highlight one notable study from the USA in 2007, which was a prospective enrollment of more than 1,000 children assessing 42 neuropsychological outcomes. And they measured thimerosal exposure retrospectively from medical records, and they included exposure from immunizations, immunoglobulins, and prenatal exposure. Overall, the results did not support an association between thimerosal and an increased risk of neuropsychological outcomes. There were a few associations, both positive and negative, which are consistent with what would be expected due to chance when conducting a large number of statistical tests. Next slide, please. So GACS has reviewed this issue multiple times between 2002 and 2012, including comprehensive reviews of pharmacokinetic studies on ethyl mercury and epidemiological studies of neurodevelopmental outcomes. And the conclusion has been that thimerosal-containing vaccines do not increase the risk of autism or the risk of many other neurodevelopmental outcomes. Since this time, thimerosal has been removed from routinely used pediatric vaccines in most high-income countries as a precautionary measure. It's continued to be used in low and middle-income countries due to its role as an effective preservative, and it's noteworthy that in countries where thimerosal has been removed, the prevalence of neurodevelopmental disorders continues to increase. Next slide, please. The third topic is autism. Next slide, please. Autism spectrum disorder is a developmental disability that can cause significant social, communication, and behavioral challenges. This issue really came to prominence in 1998 through a Lancet paper, which has since been retracted, which suggested an association between MMR, measles, mumps, rubella vaccine, and autism. Thimerosal has also been linked to autism via claimed neurotoxic effects, and aluminum adjuvants have been postulated to cause autism via neurotoxicity. Proponents of a vaccine autism link note the anecdotal observation of autistic signs developing immediately or shortly after vaccination, and a supposed autism epidemic coinciding with expanding immunization schedules. The natural onset of autism symptoms also does coincide with the age of some childhood vaccinations. Next slide, please. There are many large, well-conducted studies which indicate that the administration of vaccines are not associated with an increased risk of autism, and these include several large cohort studies done in Denmark, which involved hundreds of thousands of participants. And through these studies, there has been found no significant difference in the rate of autism between MMR vaccine recipients and non-recipients, and no association between thimerosal content and autism. There have also been reassuring studies from the UK and the USA, both cohort and case control studies looking at MMR vaccination and autism and thimerosal and autism. And the notion of an autism epidemic has been disputed. There is increased recognition of the condition, including less debilitating manifestations on the autism spectrum, and the observation of early autistic signs after vaccination can occur by chance. Next slide, please. The committee reviewed the issue of MMR vaccination and autism in 2002 and concluded that there was no evidence to support a link. They also reviewed thimerosal neurodevelopmental disorder associations, including autism, a number of times between 2002 and 2012, and they concluded that there was no support for a link between thimerosal and autism. And since this time, there has been a meta-analysis done which confirmed that vaccines do not increase autism risk, and there's an increasing body of evidence which supports that autism is predominantly a genetic disorder with an inheritance of up to 80%. Next slide, please. The fourth topic is autoimmunity. Next slide, please. Autoimmune diseases include a variety of different pathologies, including multiple sclerosis, thyroid disease, and autoimmune encephalitis. The association between vaccination and chronic autoimmune conditions is largely based on the concept of molecular mimicry, autoantibodies which are produced after exposure to an infectious agent. And the phenomena has also been linked to some natural infections such as group A strep and measles virus. Next slide, please. The postulated link between vaccines and autoimmune conditions has been extensively explored via controlled trials, observational studies, and epidemiological analyses in multiple countries and in subpopulations. For hepatitis B vaccine, it's been found a lack of association with rheumatoid arthritis, thyroid disease, or MS. For human papillomavirus vaccine, there's strong evidence against an elevated risk of GBS, central demyelinating disease, and MS. Studies have also demonstrated no increased risk of autoimmune disease, including MS among girls who receive HPV vaccine compared to those who did not. There is a retrospective cohort study which was done in France with millions of participants, which found a similar incidence of autoimmune conditions in vaccinated and unvaccinated populations for all conditions studied except GBS. There was a small increased risk, which was mainly focused on the first 3 months after vaccination. And the last bullet on the left-hand side of the slide actually refers to a different study. I had a formatting error here. This is a review of safety data from Denmark and Sweden in 2017 among 3 million people. And that study found an increased risk of celiac disease after HPV vaccination. But the authors concluded that this most likely represented an unmasking of an existing condition during vaccination rather than a causal association. For influenza vaccine, it is noted that there's a small elevated risk of GBS, but the risk is considerably lower than the risk of GBS after natural influenza infection. And for adjuvanted H1N1 influenza vaccine, there is evidence of a causal relationship between narcolepsy among school-age children with a genetic predisposition, but natural viral infection may have played a role as a vaccine-enhanced viral immunopathology rather than an isolated vaccine-induced autoimmune event. Next slide, please. The committee has reviewed the data on the possible relationship between autoimmune conditions and a variety of different vaccines over the years between 2002 and 2017. HPV vaccine has been a major focus due to public concerns. And the committee concluded that studies have demonstrated that there's no increased risk of autoimmune disease, including MS, among girls who received this vaccine compared to those that did not, but that additional studies with adequately sized populations would help evaluate the finding of increased GBS risk. GEX also released a communication about HPV vaccine safety to address misinformation. Next slide, please. So in summary, for autoimmunity, the temporal association of autoimmune diseases with vaccination overall is not sufficient to support a causal relationship. Evidence supports that vaccines do not increase the risk of autoimmune disease. The challenge is that there will be temporal but not causal relationships, and this poses a challenge for communication. Next slide, please. The fifth topic is immune overload. Next slide, please. The number of antigens recommended via routine immunization during infancy has increased in the past few generations. Immune system overload, the concept is that the body either has a reduced response to multiple antigens given at the same time, or that an individual is more vulnerable to infection after vaccination due to immune system weakened by response to multiple vaccine antigens. And because of this concern, particularly in high-income countries, there is some delayed or alternative dosing schedules used by some parents. Next slide, please. Multiple studies have assessed immune response to different vaccines and vaccine combinations, whether administered concomitantly or as a multi-component vaccine. Randomized controlled trials and epidemiological studies of MMR vaccine have shown a similar immune response, whether given singly or in combination with other vaccines, and no increased risk of invasive bacterial infection up to 90 days after immunization. MMR has been shown to have no interference with response to other vaccines given concomitantly. Some studies have shown that non-MMR combination vaccines reduce immunological response due to individual components. There's a randomized trial of co-administration of DTaP and Hib done in Finland and found differences in the Hib antibody concentrations observed in the group receiving the Hib vaccine mixed with DTP when compared to groups receiving the vaccine separately. However, it's estimated that infants have a theoretical capacity to respond to about 10,000 vaccines at any given time, and that only about 0.1% of the immune system would be quote unquote used up if 11 vaccines were given at the same time. Next slide, please. GACS looked at the issue of immune overload in 2006, and they concluded that the available evidence did not support the hypothesis that vaccines weaken or harm the immune system. They also stated that additional epidemiological studies assessing the presence of an association between vaccines and recurrent infant infections would reinforce confidence in infant immunization programs. And since the time of this report, there's been a large body of new evidence that has accrued, indicating that the number of vaccines or vaccine antigens do not increase the risk for other infections or other conditions. Next slide, please. The final topic is non-specific effects. Next slide, please. This concept is that vaccination induces protection from or susceptibility to infections not targeted by the vaccine. And this has been posed for BCG, DTP, and measles-containing vaccine, and to have an effect on all-cause mortality. The causal mechanism is not well defined, and there's little consensus on if and how non-specific effects should inform public health policies. Next slide, please. BCG, DTP, and MCV-containing vaccines, their effect on all-cause mortality was reviewed by SAGE, the WHO Strategic Advisory Group of Experts, in 2014. And the group concluded that the overall evidence base for the effects of specific vaccines on all-cause mortality is not strong. And then in 2016, WHO commissioned a systematic review looking at these same vaccines and also reviewing many of the same studies. They noted that most of the evidence from observational studies comes from observational studies and some from short-term clinical trials, and that the evidence suggests that the receipt of BCG and MCV may reduce overall mortality by more than what would be expected, but through their effects on the diseases that they prevent, and that the receipt of DTP may be associated with an increase in all-cause mortality. And below this bullet, I have more specific details about BCG, DTP, and MCV vaccine, but I'll just go on in the interest of time. Next slide, please. So GACS reviewed this issue a number of times between 2002 and 2008, and they stated that further studies specifically designed to address both positive and negative non-specific effects were needed, and they concluded that the evidence wasn't sufficient to warrant changes in global immunization policy. Since that time, I have already mentioned the SAGE review that was done in 2014 and the systematic review that was done in 2016. But to summarize that review again, no conclusive immunological evidence is there to support the presence of clinically relevant, geographically generalizable, non-specific immunological effects after BCG, DTP, and MCV vaccination. Next slide, please. Next slide, please. So during 1999 to 2019, GACS has reviewed several key topics at the center of vaccine safety discussions. The committee found a lack of an association between different vaccinations or ingredients in autism, autoimmune conditions, and immune overload. The evidence on nonspecific effects is not sufficient to warrant changes in global immunization policy. Next slide, please. Next slide, please. So robust scientific studies from multiple disciplines are needed to make adequate conclusions at the global level. And you also need an abundance of data on the safety of immunization and their components. Also importantly, there needs to be pre-licensure and post-licensure safety assessments, as well as surveillance data from multiple sources in epidemiological settings. And communication messages are particularly important to reduce fear and encourage vaccine uptake. Next slide. And this is just a few takeaways about the issues of public concern in this COVID-19 era. I want to note the complexity of doing safety surveillance during mass vaccination activities, particularly in low and income settings. There is, of course, this rampant COVID-19 infodemic, and the role of social media in propagating vaccine hesitancy and refusal is still there. And because of all of this, communication regarding settled vaccine safety issues is critical. Next slide, please. So for more information about the GACS reports that I mentioned, here is a link to the GACS website. Next slide, please. And that's it. Thank you very much.
Thank you, Dr. Jelani. Are there any questions or comments from members of the committee, either online or in the room? John Dunn.
Hi, thank you very much for that. That was terrific. I love things like that because they remind me of stuff that I think I already know and let me know that I'm not off base, which leads to one of my comments. As you point out, communication about this is critical. Getting the end user, which is to say people who are going to get vaccinated, to pay attention to info and data like this is very difficult. On the other hand, for the people who are trying to convince them, for providers, for other healthcare personnel, for influencers, it's said that the people who are the best salespersons for any product are the ones who truly believe in it. And as you were giving this, I was wishing that everybody in my organization could listen to this half hour, because it would reinforce those who occasionally hear a lot of stuff and sit on the fence and wonder if they're missing something. It would reinforce that, no, we really do know this. Has there been put together from this any sort of cut down brief equivalent to what you just gave as an education module directed not at the public but at providers and at healthcare personnel, either as continuing ed or as other things that they could use for self-education? Does something like that exist? I think it would be really valuable.
Thank you. I appreciate that question. And so I work in the global immunization space. I'm not as familiar with the education that's done in the domestic space for vaccine safety issues for providers. I know that WHO, for example, they produce a lot of different materials about general vaccine safety specific issues. But to be honest, this is from a review that was done, and I haven't seen any other training modules on all of these topics together. I would also like to see if any of the other contributors to this session, maybe they have some more information about this in the domestic space, but I think it's really important that those providers can reinforce those safe messages.
Thank you very much. Overall, this was the right content at just the right depth to really provide a lot of people with what they need. I appreciate it. Thank you.
Thank you.
Great, thank you. And again, a comment in the chat from Chris Arisman about this being a very helpful presentation. So please share our thanks with your colleagues at the CDC that have also been involved in this work. I want to thank all of you for your participation. Thank you for your presentation, Dr. Jelani. This ends our morning session for our September NVAC meeting. We'll now adjourn for lunch, and we'll return at 1 p.m. Eastern Time for a booster protection, booster doses, and strategies, our next panel. Thank you.
Produced by the U.S. Department of Health and Human Services.